Welcome to the 8 Minute Rule podcast, where actual physical therapists share clinical pearls designed to create conversation around what's getting results in the clinic. No fluff, no Medicare stopwatch, only quality content. Welcome back to the 8 Minute Rule. I've got a special episode now with Mark and Drew in the same location. Very fun, guys. Good to see you guys. Lucas may hop in at any moment. Who knows? We'll see. We'll have some fun today. What has our attention? We talked about subjective last episode. Going to dig a little bit deeper into objective and kind of do a little kind of whole SOAP progress for visit evaluation specifically here. So what I want to give you guys feedback on is objective measures. But first, for a nice little icebreaker here, for both of you guys, what is your favorite shoulder special test?
Is none an answer?
That would probably be valid.
I'm always of the belief everything we're doing is kind of a special test. Like we're trying to identify structures, quote, special tests that have research around them, just have data points with them. So I kind of view them somewhat differently as from maybe some people, but I think trying to identify only one thing all the time is not great.
I would agree with that. I think about the only one to use would be like biceps load. That's about the only special test that I've really used with any regularity in practice.
You use them, you just don't think about them like that.
Well, that's true. And even then, I would say that I don't use that one frequently.
Guys, to any of the new grads whose mind we just blew with that, yes, we're going a little more clinical off of the shoulder. In reality, not many of them have great numbers. However, we're not saying you can't do them for sure. That's not what we're advocating here, but appreciate you guys' feedback. Anyways, bypassing that, we're going to dive into objective. Really, the first overarching view I want to look at is, as we're trying to tease out, you went through subjective. You guys did a really good job of identifying the sins, trying to figure out where the irritability sits on this. Asked a lot of good questions, worked on the funnel down approach. We got there. Now as we're digging into the objective portion of evaluation, what I really want to go through first is we've kind of identified this patient's a little more in that chronic pain bucket. You know, the symptoms have been going on longer than 6 weeks, but it doesn't always have to be by a specific time frame, but you're kind of starting to recognize there's a little more to this than just, hey, acute injury, we're just treating the structure. So Mark, give me some feedback. What is it that you're looking at as you're trying to think through how you're going to lay out your objective testing for this chronic pain patient?
Well, first and foremost, this kind of goes back a little bit to the subjective, but you want to try to be able to identify and quantify yellow flags. And so I encourage screening for it, and that's usually through questionnaires. But most of the folks that you're going to be seeing with really chronic and persistent pain are going to have those as underlying things that you can do all of the best exercises and manual techniques, but if those other things are not being addressed, then you're only going to get so far. So I'll preface that by saying that. And then looking at objective, I'm not necessarily going to be breaking out the goniometer and measuring the tiniest little angle difference in range of motion. What I'm really going to be looking at is how do they move, how do they function. I'm looking at bigger, larger movement patterns and seeing how they respond to them. And I may not even get NPRSs associated with these because I'm trying to shift the focus away from pain and this pain scale, shift their brain away from it.
All right, so quality over quantity potentially with this chronic pain and kind of moving them away from focusing on the pain side of things is what I'm getting from Mark. Drew, you got anything to add?
I agree with that, definitely, but I'll look at maybe quantifying how much of this do I think is nociceptive versus neurogenic versus neuroplastic. And if it's a primary nociplastic where it's a central driven thing, it's certainly going to look different. I probably won't. I'll maybe break out the oculometer instead of the goniometer and do some estimates. But I'm looking at the bigger picture. What are they doing in general? How are they moving when they do the functional activities? And maybe there's some modifications that we can do to help just start calming down the symptoms. And that could be anything from looking at the psychosocial components to modifying positions, activities, so that they can do what they need to do, but start to just calm that nervous system down.
Yeah, I like the shift of kind of more general movement and really trying to change out how we're going to approach this population. I do think there's some value in we still want to be able to get some measurables for test retest, right? I mean, we still want to be able to find some things.
Yeah.
Have you guys found? I was gonna say, have you got at least some thoughts of some specific things that you're trying to think through? How am I going to get this patient to really recognize progress in the future?
Yeah, I think one of the big things is making sure that you are measuring what you want to change. And for those really high central driven pain patients, looking at things like 2-point conversion or 2-point discrimination and pain pressure threshold are keys where you can get some pretty solid objective measures and not just some questionnaires.
I will say the questionnaires, they have been shown to also be good asterisks for test, treat, retest, but that's, again, subjective, not objective, and it's usually between a few sessions, not necessarily one to the next.
Yeah, I like it. So kind of, at least with this population, looking a little more 2-point discrimination, the pain pressure threshold, really kind of looking the outcome measures and different things like that as well too. I think those are really helpful. I think for me as well too, I've done a lot of sleep quality and all of a sudden just going back to the simple stuff. I mean, it could even simply be how many glasses of water are you drinking a day? How many 10-minute walks are you taking? I mean, it doesn't have to be complicated stuff, but really kind of turn it into how can we create some success for this population? Because a lot of times they're just getting dumped on by everybody else. Like, well, you need to diet and exercise, and they're like, well, how do I do that? I hurt every time I walk for 30 minutes, and so you're trying to tone down and give them a successful platform to work into, which I think is really important.
I want to add one other thing, though. Like, I'm looking at all these things, and something that is super important for this population is making sure you are doing a very thorough examination, especially on the objective side, for a couple of reasons. One, so that they have some of that buy-in, that they know, hey, this is the right place. They know what I'm doing, and you're not just writing them off of saying, oh, where they think it's all in your head. It's not a real thing. So that's really important. And then recognizing where there are some potential nociceptive components that you can address and really capitalize on some of those small wins are definitely important as well. So there's the other side of not writing them off too quickly and making sure you're doing a very thorough examination, picking up small wins when you can make those changes, and then getting that patient buy-in is key.
Yeah, last thing I'll add on that is oftentimes when you get these people and their body charts, it's like really colored in and there's a lot of things going on. You may also need to do a more thorough, not necessarily more thorough, but a thorough objective exam to make sure that there's no red flags going on, because the differential diagnosis for like chronic persistent pain, widespread central sensitization, one of those differentials is red flag conditions.
Absolutely. And I appreciate you tying that back together, because I think sometimes we're trying to figure out, okay, maybe we're not special testing as much, maybe we're not breaking out the goniometer. There can be a little bit of a blend to think this is just kind of a thrown together evaluation. But, and a lot of that's reading your patient as well too. Like, what are they biting into? Are they, if you're talking about chronic pain or you're talking about desensitization, their eyes are rolling back of the head, you're trying to get into a different place as well. And some people are going to really need to see, hey, I want to see them breaking out and looking at some specific numbers. I want to see them at least looking at those things. So I think it's important to make sure, just what you talked about, Margaret, you can still utilize some different techniques outside of goniometer and things like that and be thorough. And how do we make sure that we're approaching both those things for this patient, and also recognizing that it doesn't have to look completely traditional to all of our evals as well too, and you can get a lot of it. So real quick, again, just in terms of entering that into kind of importance, under testing versus over testing on special testing, you guys have any quick tips on that? Both of you, about 30 seconds.
Don't over-exam the highly irritable and don't under-exam the low irritable patient is the key thing.
So that means basically, like, if you need to be able to reproduce symptoms in someone with low irritability, so you may have to really dig for it and really try to progress your forces to provoke a little bit. But with someone with high irritability, you may not want to do your provocative tests. If they're coming in for a lumbar or a dick and you think it's pretty acute and irritated, Don't sit them on the table and do a slump right out of the gate. You may not even need to do a slump at all in those cases. So that's kind of what that concept means.
Well said. I think that's really helpful because chronic pain, you're going to have both high irritability and low irritability, and so you got to be able to tease that out and make sure that you don't just absolutely make the patient feel miserable after that initial eval. They're probably not coming back. So, well, good stuff, guys. I think we'll actually stop there and hold for next time when we tackle a little bit more potentially of the acute side of things there. So, appreciate you guys. Until next time.